that better? All right. So the drug therapy for infertility really hasn't changed in the last like 15 years. But you're seeing more and more patients using it as a result. And there is a big campaign of awareness just because it is something that a lot of patients don't talk about. And it is something that is on the rise. So infertility is defined as the inability to conceive after 1 year of trying. So when you think of like, the typical person, and I'll use me and a lot of my friends as examples because most of us have kids, and most of us went through the whole process. So what usually happens is like when you get to the point where you want to try to have a child, most people think that it happens instantly, right? So you like, and I was the perfect example because I was like, oh, I want a baby, so, and I like counted 10 months back, and I was like, oh, I'm gonna get pregnant in August, and that will give me a May baby, you know? And unfortunately, it just doesn't work like that. And so what we really encourage patients is to not plan the way I wanted to plan to have my May baby. I don't have a May that way. I do have an April baby, she came out late. But it's really that inability to conceive after 1 full year of trying. So people think, oh, I'm gonna have intercourse this month, and I'm gonna get pregnant, and it just doesn't work like that. So we really encourage most people to try at least for 1 year before they go to an RE with the reproductive endocrinologist, before they try any drug therapies. And most patients, most females actually, are born with a number of eggs, right, in their lifetime. And every time they go through a menstrual cycle, they'll lose 1, maybe 2 eggs per cycle. And so as you get older, you will have less eggs. And as a result, we encourage patients that are over 35 years of age, if they're trying to get pregnant after 6 months, to go and see an RE because of the fact that we want to make sure that they have enough eggs. And typically, the earlier you had your menstrual periods, the quicker you will become infertile. Okay? And so primary infertility is basically that the couple has had a child before, and they're having difficulty trying to get pregnant. And secondary infertility is defined as someone who has a child but can't get pregnant or can't have another child. And then the fecundability is the probability of getting pregnant within a menstrual cycle. And so most people have a 20 to 25% chance of getting pregnant within the cycle that they want to get pregnant. And that's why we encourage patients not to do what I did, which is like try to plan and say, I'm gonna get pregnant this month, because your chances are pretty low. It's 20 to 25%. So epidemiology, it is rising, but the numbers haven't changed that much over the last 10 years. It's 1 in 10 couples in the US that are are infertile. And it takes most couples at least 1 year to get pregnant. And so they say within 85% of couples within 1 year will get pregnant. And that's why we encourage them to go after 1 year for treatment. And percent of married women aged 15 to 44 that are infertile is about 6.7%. And then the amount of patients that use some kind of service to get pregnant is around 12%. And then this is just kind of showing you the number of how long it takes patients to get pregnant. So if they, remember I told you the 1 month, if within trying in 1 cycle, the likelihood of you getting pregnant is 20 to 25%. So within 3 months, it's 57%, 6 months, it's 72%, at 1 year, we're at 85%, and then at 2 years, you're at 93%. And then 10 to 13% of couples remain infertile, with that age group from to 44, 18 to 44 is around 12%. So factors contributing to infertility. So these are the things that are risk factors that will help us identify what we're with patients, whether we need to treat them with something. So age over 35, and that's why we usually have those people go for analysis. And so we usually will look at when a patient comes in, and usually it's a couple problem, right? So when somebody comes into the reproductive endocrinologist, the first thing you're going to talk to them about is, let's figure out what the issue is. Is it a male problem? Is it a female problem? Is it a combined problem? And so the easiest way to assess someone to figure out if they have eggs is by doing lab work. And so that's usually the first thing we do. So age over 35 is definitely a risk factor. And then anyone who has pelvic inflammatory disease. So if they've had an STD like gonorrhea or chlamydia, they usually had inflammation of their uterus, their fallopian tubes, potentially affecting their ovaries. And so they usually say that there is a risk associated with it, whether they have a current gonorrhea, chlamydia infection, or if they've had a past infection. And so that is one of the risk factors, and we typically will ask for that. And it's usually related to the fallopian tubes. So cigarette smoking is also a risk. Nicotine actually blocks sperm formation, and it actually decreases your testicular size as well. So if you have a male who is currently smoking, we really encourage them to decrease or do smoking cessation while they're trying to get pregnant. And usually sperm formation is around 90 days. And so we'll encourage them to stop right away because the potential for that helping is higher. And then marijuana also inhibits sperm formation. So if your patient is a smoker of marijuana or uses any kind of marijuana, you would discourage them from using that as well. And then obesity, we encourage the female to lose weight if she's overweight. And then there's controversial stuff that you don't need to know about, but this is an important slide for you guys to know, risk factors. I love risk factor slides. Right? Okay, so medications affecting fertility, usually with alcohol. And this is an important slide for you to know just because these are the things that we could potentially encourage patients to stop taking a certain med if we can, right? So sometimes you're not going to be, so you're not going to be able to. So if a patient has high blood pressure and they're on a calcium channel blocker, it could potentially cause impotence in men, and so we would switch them to another medication within the hypertension class, medications that doesn't cause infertility. And then alcohol causes impotence in men, antidepressants. And there is a slide later that focuses just on sperm formation. So some of this stuff, some of these medications affect fertility in other ways, but there is a slide later that I want you to know that will talk specifically about sperm and decreasing sperm count. All right, so this is really, and I printed a copy of this for you because this really does talk about everything that you need to know about the menstrual cycle. So when you're thinking about your drug therapy, this is gonna be where everything is affected, okay? So first I'm gonna talk to you guys, and you don't have to write anything down. All you have to do is pay attention because everything I'm gonna say, I wrote down in the next 3 slides, okay? And so you'll see like in the next 3 slides, I think it says like days 1 to 4. Let me just get it so that I know what you guys are looking at. So if you look at the next couple of slides, it says like days 1 through 4, day 14, days ovulation day through 28, okay? And so when you're looking at the next 3 slides, that explains this diagram in detail with what I want you to know. So what usually happens is, there's a couple of things I want to orient you to on this. So the bottom thing with menstruation here, you don't really need to know, but it's these hormones that I really want you to understand. Can you see the pointer, like when I'm pointing or not? So, okay, I'll use my mouse. So if you look here, you can see that there's different hormones, and the hormones really, when you're looking at the drug therapy for infertility, you really have to understand the hormonal process to understand why we're using certain drug therapies. So what I did was, when I talk about the drug therapies, I'm gonna bring this diagram back because I'm gonna kind of show you where they actually affect. And then body temperature is important because sometimes they monitor, so I'll talk about that, and then I'll talk about ovarian history. So what happens is, well, when we talk about menstrual cycle for females, right? What we usually do is we put it in a 28-day cycle. Most females will have a 28-day cycle. Some will have a longer cycle, some will have a shorter cycle. So depending on the female's menstrual cycle, if they have a 40-day cycle, then they may not ovulate day 14. They may ovulate at another period of time. And so what happens in the normal menstrual cycle is phase 1 is called the follicular phase, and this is usually days 1 through 4. And so what ends up happening is you have eggs, right? And every cycle, the female is going to release an egg. And the egg is usually released day 14. So when that egg is released, you have around 24 hours to impregnate that egg with a sperm. And so what will happen is in the day 1, your follicles are released here. And all of the follicles, and you can see how they get bigger and bigger as ovulation, as they get closer to ovulation. So a bunch of follicles will compete with each other to try to become the dominant follicle, okay? And the biggest follicle, the most dominant follicle, is the one that will release the egg. So when you look at day 1 or even day 4, you'll see that there's a bunch of follicles that the female's body is trying to release eggs. But typically, we will only see 1, max 2 eggs being released at the time of ovulation. If 2 are released, that's when we see the fraternal twins, right? So if somebody releases 2 eggs and both of them get impregnated, the female is gonna have twins. And so what happens day 1 is you see this FSH increasing, and so this is your red line right here. So you're slowly seeing that FSH increase. And as soon as the FSH increases in your body, you're gonna start sending out follicles to get bigger. So days 5 through 7, you'll usually have 1 follicle, and this is in a normal cycle. So this is not when we're talking about infertility treatments. This is in your normal patient. So in your normal patient, you'll usually have 1 follicle that's dominating, and that follicle will be usually the one that will release the egg. And so what starts happening around days 5 through 7 is estradiol starts increasing. And as soon as estradiol starts increasing, that tells your body that there is 1 follicle that is dominating, and as a result, you'll see FSH decrease, because your body is telling you, your FSH decreasing will tell your body, don't produce any more follicles, there's 1 follicle that is dominating. And so the FSH starts decreasing, and as the estrogen starts increasing, your body will start preparing the endometrial lining, so that if the egg does get fertilized, your lining will be strong enough to hold on to that egg, okay? And so the quality of your mucus, all of that will improve, and your endometrial lining will increase. And then days 13 through 14, what you'll see is this huge surge in LH, okay? And so when you see this surge in LH occur in your body, that will trigger your body to ovulate, okay? So that LH surge usually occurs about 24 hours before you actually ovulate. And so once that LH surge occurs, the follicle matures, it ruptures, it releases the egg, and it allows penetration. It allows that egg to be penetrated. And so day 14 is typically when that LH surge occurred, anywhere 24 hours before. And now day 14 is the day that your egg is released, and it could be fertilized. And the egg typically will survive for about 24 hours. And so what we usually look for when we're educating patients on using their hormonal tests, like the urine test, which I'm going to talk about, we'll usually educate them that, make sure that once you see that rise in LH, that you start having intercourse, a couple times during that 24-hour window to fertilize that egg. And then sperm typically will survive 48 hours. So you could actually technically have intercourse the day before your egg is released if you predicted it, using one of the urinary tests or one of the watch that I'm going to talk about in a few minutes. So if you know that you're gonna get ovulate tomorrow, you could technically have intercourse tonight and it would still be okay because that sperm will still be around when the egg actually is released. And so then you have your luteal phase. So that's so you look at your follicular phase. As soon as you ovulate, you'll start seeing that the LH decreases and your estradiol decreases as well. And so then what ends up happening is your body starts creating progesterone, because progesterone is what is going to make your lining thicker. It's what's going to hold on to that pregnancy if you did fertilize that egg. And so you'll usually see progesterone peak after. And then it'll maintain the lining. And then at day 28, if the egg was not fertilized, it'll start back over. So your progesterone will go back down. And then as a result, that will tell your body that, hey, you need to increase the FSH to restart the whole process. If the egg was fertilized, your progesterone will continue to increase and make sure that uterine lining is supported appropriately. Okay? Does that make sense? Okay, so while this is all happening, you'll see that right before, if you look at your body temperature and look at this degree, so it's 36 degrees Celsius and 37 degrees, so it's really only a 1 degree difference. And so you could see that right after you ovulate, right here, there's a small increase in temperature, in your body temperature. And so what a lot of people do is they'll monitor their basal body temperature in the morning, first thing, females, to see when they ovulated, to kind of predict that, hey, I ovulated today, I should have intercourse today. So, and I'm going to talk about that in a few minutes, but I just wanted to show you that you see there is a small increase in temperature here. All right. So predicting fertility is based on a 28-day cycle typically, and the highest days that most females fall is between day 10 and day 17. And so 30% of females fall into this category. And it's complicated sometimes by people who don't have that 28-day. And if you don't have a 28-day cycle, but you have a 30-day cycle, it's pretty much the same. But if you have a 50-day cycle or a 90-day cycle or a 12-day cycle, it becomes a lot more complicated to kind of predict when you're actually ovulating. And that's when we use some of the female fertility tests to kind of try to help us predict when ovulations occur, okay? So there are a couple slides I'm gonna ask you, and that's why I actually wrote down exactly what the graph, the picture that you guys have is. And so I do want you to know the last couple slides of what hormones go up, what hormones go down. And I'm not so concerned, like if I go back, I'm not so concerned about, I want you to know that LH peaks right before ovulation, and then in the first half of the thing, you'll see a small increase in FSH, which increases your follicles, and then as a result, estradiol goes up. Okay, and then I want you to know progesterone is your second phase. Yeah, and the way I worded it was the way it's written on your slides, and so so the way I wrote it is like, see, like I wrote days 5 through 7, and then I told you exactly what happens. So in the test questions, I asked you the same way, like during days 5 through 7, during days 13 and 14, during days 28. So I do want you to know these couple slides that I went through. Okay, so female fertility test. So this typically was a lecture that we used to cover in the self-care class, and we took it out about like 8, 9 years ago because we didn't have time in the self-care class, and we had time in this lecture typically. But what I did was a lot of the stuff I eliminated for this lecture for you guys because of the shortened class period. And so I'll go through the main things that you need to know for predicting fertility, but there are some other things that I'm not going to cover in this lecture that are available over the counter. And so the purpose of female predictor test is to identify when the patient's ovulating so we can fertilize, right? So I talked about basal body temperature. So we know that there's a small increase in basal body temperature after ovulation occurs. What do you think the negative of that is? So if I'm a female, right? And every morning I'm checking my temperature. And today I see a small peak. What do you think the negative would be of the basal body temperature? And it's not written in your notes. So after ovulation occurs, right? So you see that this gray line right here, or this gray line right here. Okay, so see this gray line right here? So you ovulated, you released your egg, and now you have a spike in your temperature. So how long does the egg survive? 1 day, right? So what if I ovulated like 19 hours ago, and now I'm waking up and I'm checking my temperature, right? So that's a big negative, and it's something that's cheap and inexpensive. So with basal body temperature, you just buy a normal thermometer, okay? And what you're supposed to do is, for resting temperature is usually below that 0.1 degree difference. And so when I'm in bed and I check my temperature first thing when I wake up in the morning, if I do it every day, I will see that small peak when I ovulate. But it's only resting temperature. So if you get up out of bed and start walking around and then remember that, oh, I was supposed to check my temperature, it's too late. Okay, once you start being active, your temperature is going to increase automatically. And so the important thing, if somebody's going to use this is the cheapest way. You could buy a thermometer for like $10. And the ovulation predictor tests are a lot more expensive. And so if someone's going to use this, it's really important to make sure that they're a person who's going to remember first thing in the morning, they check temperature. And so after ovulation, they'll see a small increase, and then they should have intercourse immediately. Okay, so it really doesn't have much room for planning because ovulation already occurred. So if you see that rise today, that means you ovulated, and you may have ovulated 20 hours ago, and you may have ovulated 1 hour ago. So regardless, you have to have intercourse now, okay? And so that's what we tell patients. Interferences, like I said, if you start moving, if you're stressed or you're emotional, if you have an infection that's going to increase your temperature, those are all things that ideally will affect your readings for that cycle. And the other key counseling point that we have to tell patients is that they have to be sleeping for at least 5 hours. And so if they haven't slept for 5 hours, their temperature is not going to have enough time to go back down to resting state. All right? So I don't really recommend basal body temperature to anyone when they ask me. I usually will go to urinary hormone tests because they're a lot more accurate and they give you a little bit more planning time. But if somebody's looking for something inexpensive, that's probably what you're going to recommend. So the urinary hormone test, what they look for is they look for an LH surge. Okay, so the LH surge occurs when? Compared to ovulation, how long before? 1 day before, right? So what they're looking for is that surge to occur, and then you know that once you get that smiley face or you get that plus sign, that you're gonna ovulate in the next 24 hours. So it allows people to plan a little bit more where you're not like, I gotta have intercourse now, right? So it allows people to say, all right, tonight's the night, we're gonna do it, okay? Or tomorrow morning, whatever. But they have about 24 hours. And we usually have them test first thing in the morning. So your urine is most concentrated first thing in the morning, so you'll usually get a more accurate reading if you use the urine in the morning. So infertility treatments usually interfere with some of these tests because you'll see when we talk about some of the treatments that a lot of them will give you artificial LH or will give you GnRH, which alters your LH. And so as a result, if you're on fertility medications or doing fertility treatments, you can't use the urinary test because they're going to give you false positives, okay? Or false negatives, depending on which treatment you're using. If they have PCOS, if they're in a menopausal state, they will have false positives, and also pregnancy. So if there was someone who had a pregnancy and they miscarried, their LH will be higher than what these tests are designed to detect, and as a result, it may tell you that you're ovulating when you're not, okay? And so those are the patients that we would exclude. And so what we typically will tell patients is if they have an idea of when they're ovulating, and we know, like I told you, that most women will ovulate between day 10 and 17. So if someone comes to your pharmacy, and these are all over the counter, so if someone comes to your pharmacy and they're like, oh, I'm thinking about using this test, when should I start using it? usually you'll recommend, if they're in a normal cycle, 8 days, you'll say, start checking day 7, or start checking day 10, okay? And so a couple days before and if they know like exactly when they ovulate, then you would tell them, you try to start 2 to 3 days. So let's say I'm a female that I've been using these tests for a while, right? And I know that on average I ovulate, day 17 to 19. Then typically I'll start using it 2 to 3 days before day 17 to try to decrease the amount of sticks I'm using. Okay? You're falling asleep, I can see you. Need to stretch? I know this is boring. Okay, so these are your tests. So look, there's a smiley face test. How exciting, right? Did you guys see this on the product display the first day of self-care? Did we have them out or no? Okay. So usually at the product display, this semester was all messed up because you guys we had self-care on Mondays. But typically during the product display, we'll show you guys what the smiley face looks like. And Dr. Bridgman sometimes pees on them for a week straight to try to get a smiley face so you can see what it looks like. But maybe I'll convince her to do it for one of your lab sessions. And so what happens is, and I did use these for my second daughter, for my daughter. I told you I wanted a May baby, so I was like, I'm going to use these tests and know exactly when I'm going to have it to have a May baby. And so there's pros and cons to both. So there's tests like this over the counter, like this one on the left-hand side. And basically, what it'll do is it will tell you when the LH surge is going to happen. And so you pee on these sticks every single morning, and you'll see a line like this where you see a fainted line and a darker line. And that means that there's no LH surge. So what you're looking for is an exact match, So every day that you're using this and you're getting closer, this second line gets darker and darker. But even for me, who teaches this lecture, it was so confusing. And so the first month I tried these and I was like, oh my God, this is so confusing because your line gets darker and darker and you're like, is it an LH surge? Is it not? And so what they did to overcome people like me who can't figure out if the line is actually, so I'm like, I think I'm ovulating today, and I'm like, oh, the line's darker today. Oh, I'm ovulating today. Oh, the next day, the darker, I'm like, oh, I'm ovulating today, and it was just a nightmare. So they got rid of that, and then some of those do exist. So these are usually cheaper, and so if somebody is smart enough to figure it out, they can go with that. The people like me, there's a smiley face. So every day you don't get a smiley face, and the day you're ovulating, you get a smiley face. So it takes away that interpretation part of it. But I've talked to patients about this, and it sucks when you pee and you're trying to get pregnant and you get a non-smiley face. Like you get nothing, and you're like, ugh. But it's very exciting then when the smiley face comes up. And so what I'll try to do is I'll try to tell Dr. Bridgman in one of your labs for the next couple weeks to have both out, just so you can kind of see the differences, because it is exciting to see the smiley face, okay? So you can, and both of them work. If your patient is capable of looking for a positive result like this, then it's perfect, okay? And so what we typically will tell them is when you see the smiley face, have intercourse within 12 hours because you don't know when that egg is actually going to be released. Like that LH surge could have occurred 12 hours ago. So if I'm waking up at 6 in the morning, the LH surge may have occurred, 6 hours or 12 hours ago. And so ovulation may be occurring in 12 hours. So we usually will tell them, as soon as possible, try to have intercourse. And then there's the fertility monitor. Normally these tests are around $30 per month, okay? The basal body temperature, I told you the thermometer is around $10, it's a one-time fee. This is gonna cost you around $30 a month. When you go to the clear blue fertility monitor, it definitely becomes a lot more expensive. So it's hundreds of dollars and you gotta pay for this egg. So this is really recommended for someone who has been trying for a while or has an irregular cycle and they need to figure out when they're ovulating. It does a lot more predictive stuff. So this is something that is an option for your people that have been trying for a while. And then I'm gonna put this as an FYI slide. And then other things that you could use, there's the fertility microscope, which kind of looks like a lipstick. And what you do every morning is you lick it, and then you look in the microscope to kind of look at what your fertility patterns are. And so this is a small picture, I should have made it bigger, but you could see that anytime you're fertile, you'll see that your saliva actually has these like lines. Can you guys see it in the back? There's like lines versus little dots. And so you'll see strands together. So that when you do see those like lines, that means you're fertile and that you should check it in our course. So that's something that someone can purchase. It's under $30 and it's a one-time purchase. And then what you do is after you lick it every day, you just wipe it down to make sure that it's clean for the next lick. There's saliva electrolyte monitors, which do the same kind of look for like looking for fertile patterns, but it interprets it for you. And this saliva electrolyte monitor can be used with your mouth saliva, but it could also be used with your vaginal secretions as well to look for that firming pattern to tell you when you're pregnant. And then the OV watch, it actually looks for chloride ions. So they say that 6 days before you ovulate, you actually have a surge in chloride too. And so the OV watch monitor looks for that. But the OV watch monitor, you have to buy a sensor every month. And so it does get pretty expensive. So typically we'll use the urinary test, unless somebody wants to really plan out like romantic nights and figure it out. Then ideally, then it might make sense to go 6 days out. Then you know in 6 days you're gonna ovulate and you have a little bit more time. And then this is an FYI slide. And so you'll see some of the more common ovulation tests are listed, and it tells you the reaction time, how quickly they'll give you a reading, and then what kind of kit it is. So this is just an FYI. If you're going in community, there's a lot of them over the counter. They all are accurate. Some of them just tell you more earlier, so those are listed for you. All right, and then there is a fertility test, and the fertility test looks at sperm analysis. So basically, sperm production is influenced by physical, emotional, psychological factors. And the World Health Organization defines sperm load count as 2 test results of less than 20 million cells per ml, at least 3 days, but not 7 days apart. And so you could buy this home testing kit that allows you to measure the amount of sperm that you have. To kind of figure out, do you have high sperm count, low sperm count? But sometimes, even if you have high sperm count, it could be that your sperm aren't the appropriate shape to penetrate an egg. And so sometimes people have high sperm count, but the sperm size. Sorry, I'm going in and out. Okay, so what it does is the sperm fertility test, it's like litmus paper. You remember litmus paper in chemistry? I don't even remember what class, but litmus paper. So basically what you would do is you would get a sperm sample, and then what you would do is you would dip it, and it basically will tell you based on the intensity of the color what kind of count you have, whether it's high or low. And accuracy is around 78%. If people are using spermicidal condoms, which most of our condoms are coming now with spermicidal. So if you're looking to catch your collection in a condom, you may actually kill off some of it. So we usually will tell patients not to use spermicidal condoms if that's how you're collecting your sample. And then 2 negative tests, meaning that you have low sperm count, we usually will refer patients to an RE to get evaluated. If they have a negative and a positive, then they usually will retest in 10 weeks. But usually what we'll tell patients is if they have a negative test, we won't even wait for that second one, we'll just send them to an RE, because usually to get into an RE, you're like 3 months out. So we'll usually encourage them. All right, causes of infertility. 15% of the couples have at least more than one cause. And so we really have to evaluate the female and the male. And then sometimes we just don't really know. So 1 in 4 cases, they say we don't really know why the couple is infertile, and so we'll just try some of the drug therapies and see if they get pregnant. So if you have sperm dysfunction, which means low count, you have motility issues, or if you have size issues where they can't penetrate the egg, then we'll identify what the issue is and try to resolve it, okay? And so let's say we have a decreased count of sperm because of a drug, then we'll discontinue the drug. Let's say the shape of their sperm is imperfect where you can't penetrate the egg, then what we do is we'll try to do an IUI. And basically with an IUI, what they do is they'll get the sperm sample from the male and they'll put it into the female as close as possible to the egg so that the sperm don't have to swim as much. And usually people who have like shape issues with sperm usually will have a few good ones. And so we hope that those few good ones will go and penetrate the egg. Ovulation dysfunction, if there's a hormonal imbalance of FSH, LH, or GnRH, we'll use drug therapies I'm about to talk about. If you have PCOS, and have you guys learned about PCOS? Okay, so I'm gonna give you like a 1-minute slide on PCOS, but patients that have PCOS usually have like irregular menstrual cycles, and those patients are usually at a higher risk for getting pregnant. And so if they have an issue with PCOS, we'll treat the PCOS, and hopefully that will allow the patient to get pregnant. And then if they have fallopian tube damage, we'll do an STD test to look for gonorrhea or chlamydia, and we'll treat that. If sometimes we have to surgically go in and repair the fallopian tubes, depending. So 12-month timeline, like I said, we'll do semen analysis, and then we'll do day 3 labs. So for males, sperm, I talked about sperm formation is 90 days. Some of the medications that inhibit sperm formation are listed here for you. So I want you to know this slide. You can start the slide. And so if they are using any one of these medications or illicit drugs, we usually will discontinue it. 90 days later, we'll try to get that couple pregnant. Female evaluation will look for ovulation dysfunction. If there is ovulation dysfunction, we'll use some of the drugs I'm going to talk about. If they have PCOS, which is that irregular, absent, or heavy menstruation, what we typically will do is treat it with clomiphene citrate. So we always used to treat it with metformin, and metformin used to be first line with our PCOS patients. But if you're dealing with a patient that is infertile and has PCOS, you're going to use clomiphene citrate. Okay, and I'm going to talk about that. All right, so lab evaluation, we'll look at their progesterone levels and their anti-Mullerian hormone, and their progesterone we'll kind of look at to assess ovulation function. Remember I told you progesterone is important in that second phase, right? What does progesterone do? It helps with the lining, right, to hold on to the egg. And so if a patient comes to you and they say they're not getting pregnant, they may be getting pregnant, but they may be losing that egg or miscarrying from day 14 to day 28 if they don't have enough progesterone. So the first thing we always look at is progesterone levels to make sure that the patient has normal progesterone levels. And then anti-Mullerian hormone is used to look at ovarian function. To figure out how many follicles still remain in your ovaries. So if you have no eggs, you're never going to get pregnant, right? If you have no follicles, you're never going to get pregnant because you have no eggs. And so we'll usually kind of look at ovarian reserve to kind of figure out how many follicles are left in your ovaries for you to get pregnant. And usually if we see this lower, they'll usually go to more invasive procedures like IVF quicker, because they don't want to waste time, because every month you're losing an egg. So usually you'll go to those more harsher therapies sooner. So then day 3 labs. So day 3 of the menstrual cycle, you are supposed to look at a bunch of labs. So they'll look at estradiol to look at ovarian reserve. And ovarian reserve, and when I say ovarian reserve, I mean the number of follicles left in you. So ovarian reserve, you can look at it through the anti-Mullerian hormone you can look at it with, you got to look at your estradiol levels, and then you look at TSH. So thyroid is a big issue in our patients that are infertile. And so if it's a thyroid issue, you always treat thyroid. And the way you treat the thyroid issue is the way you guys learned. So if they have low thyroid, you'll make it normal. If they have high thyroid, you'll decrease it. And so they'll always check TSH to look for thyroid issues. And then FSH, they'll look at ovarian follicles. And oocyte is the word for egg, okay, the medical technical word. So they'll look at the quality of the egg. And prolactin is used to assess whether or not the patient's going to ovulate on time, and inhibin is used to evaluate the follicles as well as the eggs that are being released. So day 3 of their menstrual cycle, they typically will go do day 3 labs, and then based on those labs, you will figure out the drug therapy for that cycle. Okay. So be realistic. Age, you have a 50-year-old who is trying to get pregnant, is going to be a lot more difficult. Age is a big factor, and that's why we refer patients over 35. Duration, make sure that, you know, they try for at least 12 months. And the likelihood of patients getting pregnant using these drug therapies after 3 years is significantly less. So usually we won't do drug therapies more than 3 years. And then risk of treatment. So how much do you think a normal, like, IVF treatment cost? What do you think? How much? 1,000? A little bit more. A lot more, actually. It's between $10,000 to $25,000. How much do you think insurance covers? They cover it all. So most insurances, from what I've seen just practicing, is usually 1 to 3 cycles. Okay, so like our Rutgers insurance plan, I work for the state, right? The state plan covers 1 cycle. So remember what I told you, that your chances of getting pregnant in that 1 cycle aren't great. So they do, and they have a lifetime max. So a lot of people have to pay out of pocket. So what a lot of people will do is, like, if you go to a RE, they'll say, if you try for 1 cycle, we'll charge you $10,000. But if you pay us $25,000, we'll give you 6 cycles. But if you get pregnant on your first one, you still have to pay $25,000. You know, and so you'll see like plans like this. But there are, and I have a friend right now who has had 2 kids already, and she's trying for her 3rd, and her insurance is not covering it. So they decided not to have a 3rd because they're like, we can't afford it, it's too expensive. And so that is a big financial reason patients don't do some of these treatments that I'm going to talk about. All right, so PCOS, this is an FYI slide. Let me just make sure I didn't test you on that. I did not ask you anything related to this. So I just want you to know that for PCOS, and I want you to know it for life, not for the exam, but like just know that people who have PCOS have issues with infertility, and as a result, you have to treat that PCOS. So if they just have PCOS, you can use some of the drug therapies like metformin or insulin to treat it. If they have PCOS and infertility, you're going to use clomiphene citrate. All right, so non-pharmacologic therapy, weight loss. So if the patient is overweight, obese, they need to lose weight. And typically, when you see an increase in weight, that's when you see hormonal imbalances. And so typically, if the patient is overweight or obese and they lose weight, their hormonal function typically will come back to normal, and they will be able to get pregnant. So that's something that we recommend. We encourage them to avoid like excessive dieting or excessive exercise, because that's been shown to not be helpful for the baby that they're getting their body ready for, right? So we try to encourage good weight loss. Females should avoid prostaglandin inhibitors like NSAIDs and aspirin around ovulation time due to the oocyte release, because the NSAIDs can affect it. So if you have, a lot of people have this thing called Schmerz, which is like mid-ovulation, or mid-cycle cramping, which occurs usually during ovulation. And if the female, if you have it, you know you have it. And so most people will take NSAIDs, but while they're trying to get pregnant, we encourage them to take acetaminophen during that time. Avoiding vaginal lubricants, So when you're actually having intercourse, avoid using lubricants, because lubricants in the vaginal area is going to slow down the sperms from swimming to the egg. And so we'll tell them not to use that. And then making sure that they're not using tobacco or illicit drugs, because I told you that it can affect sperm motility. So there is this thing called the conception cap. I thought I put a picture in. Is there a picture in your version?
Yeah.
There is, right? Okay. So the FDA approved this in 2007, and basically it's used to get sperm to the cervical area so that it's closer to where the egg is released. And so what you do, and you can kind of see in your picture, what you do is you have the male put their semen sample into this cervical cap, and then the female actually inserts it into their cervix. So if you look at like diagram 2, you go all the way into your cervical area and put it there for a few hours, trying to get that sperm to be closer to that egg that is going to be released. Okay, so this is another option that you can use. All right, so ovarian stimulation. So I'm going to talk a little bit about each of the drugs there. So I put a picture in there for you guys in your slides to kind of show you that when we're looking at ovarian stimulation, we're looking for that increase in LH that is going to release that egg, right? Or that follicle to release that egg. And so what we really want to do is anyone who's not ovulating, and the way we're going to know that you're not ovulating is by looking at looking at all your day 3 labs, okay? But the way you would know, or the way the patient would know that they're not ovulating, is they're never going to get that smiley face, okay? And most of the time when you talk to REs, they don't even look for ovarian stimulation as an issue. They just treat with clomiphene citrate for 3 cycles and try to see if they'll get pregnant. And so a lot of times the drug I'm going to talk to you about for ovarian stimulation is kind of first line for everything. But if you have a patient, especially for your exam purposes, if you have a patient where I'm telling you that the patient is not ovulating, what you're going to do is you're going to use ovarian stimulation first line, okay? But in life, first line treatment typically is clomiphene citrate. So we're going to use it for PCOS, like I said. If they have a luteal phase defect, it helps for those patients as well. And then it's helpful for patients where we don't have an identifying cause. And so we usually use the first line. There's some different brands, but usually we use the generic clomiphene citrate. And basically what it does in the normal cycle, like I told you, the follicle produces estradiol, which suppresses that FSH from being released and prevents that LH surge from occurring. And so what happens is clomiphene citrate will block that estradiol, therefore stimulating FSH and LH. Okay, so if we go back to, let me see if I can go back to this picture so I can kind of show you. Okay, so if you look at this picture right here, when the estradiol is starting to increase, right, we see that FSH decrease. So as soon as that FSH decreases, these follicles stop producing, right? They say there's one mature follicle, and so stop producing any more follicles. So you don't see any more follicles growing to a bigger size. And what I didn't tell you earlier is, like, typically when we look for a follicle size for an egg to be released, we look from anywhere from 18 to 24. So if the follicle size of millimeters, so if the follicle size into 24, that means the egg is good enough, the quality of it is good enough to release it to potentially fertilize it. And so with clomiphene citrate, what we will do is we will block this estradiol from occurring, and as a result, your FSH continues to increase, and as a result, you have more follicles growing to release the egg. Does that make sense? No one's nodding their head yes. Does it make sense? Is anyone confused? Okay. So, let me go back. So, what happens in this phase is it blocks that estradiol, allows FSH to increase, and then FSH increasing will promote a lot more follicles to occur. So what do you think side effect of this drug is? If there's more follicles, what potentially could happen?
Does it increase the chance of twins?
Yes. So it increases, right? So if you're encouraging more follicles to grow, you have a potential of 2 eggs releasing, and as a result, you could get multiple gestations. If there's no response, and they will do blood monitoring with this too. So if there's no response after your FSH is greater than 30, then you would usually will go on to a different treatment. So this, there's a couple of ways that you could treat patients with clomiphene citrate. I only wrote one way so you don't get confused. Sometimes physicians will start you on day 3 or day 7, but you usually will continue for 5 days, okay? So you're gonna take, and so in a normal cycle, if your cycle is 28 days, you're gonna take clomiphene citrate from days 5 through 10. Because remember, days 4, 5 is where you start seeing your decrease in FSH, right? So if we give it days 5 to 10, we're gonna continue that FSH for a little bit longer. And so you'll increase that FSH for a little bit longer, and then on day 10, you'll stop taking it. So when you stop taking it, you'll see that increase in estradiol, which will allow you to have that LH surge, okay? And if the LH surge occurs, ovulation occurs. So it just allows your body a little bit more time to produce follicles that are at a good size. If the follicle releases the egg prematurely, so remember I told you it was 17 to 24. So let's say the follicle releases the egg at 12, the egg won't be able to get fertilized. And if the egg does get fertilized, it won't be a quality egg, and as a result, the patient will have a miscarriage, okay? So we want that follicle size to be appropriate before we release the egg. And so this allows you to release potentially more eggs or just more quality eggs. And then as we increase the dose, we increase the gestation of it. So I want you to know 50 milligrams, 50 milligrams is the dose, okay? And I put the brand and the generic name. So I put the generic and the brand in parentheses for you guys. Once the follicle is around 18 millimeters, ovulation can be triggered, and you can use HCG, and I'm going to talk about HCG, but HCG just basically causes that LH surge to occur, and as a result, ovulation will be triggered. But most of the time, people, and it depends on the patient, right? So if we're doing intrauterine insemination and IUI, right? So there's 3 things you could do, right, in infertility. You could just give them drug therapy and let their body handle it on their own. So you could give clomiphene citrate, and on day 10, the patient stops taking it, and your body's normal hormones will allow estradiol to go up, causing the LH surge, ovulation occurs, you have intercourse, okay? So in that process, we don't really need to do ultrasound monitor of the follicle size because we don't care. We know, hello, okay. We know that, I hate this mic. We know that once they release the egg, they're gonna, or we'll just tell them after they can have intercourse every other day, and you know eventually they'll ovulate and they'll get pregnant, right? If you're doing an intrauterine insemination, an IUI, what you do is you actually let the female ovulate on her own, but you insert, it's usually basically, think of a syringe, it's like putting sperm in a syringe and just shooting it up the female to try to get it close to the egg as possible. And so if you're doing an IUI, then the female has to go into a physician's office to get that sperm shot up. And you need the male to be there to get the sperm sample. And as a result, you have to time the ovulation, right? You can't just ovulate whenever you want. And so in that case, what they do is they have the female go every single day to the office to assess follicle size. And once the follicle size is 18 millimeters, what they'll do is they will give you an injection of HCG to cause you to ovulate right now. And as a result, they can do the IUI insemination. Does that make sense? Okay. And then the other therapies that you could do is IVF, right? And in IVF, what they do is they pull out the egg from the female, and they take a sperm sample from the male, and in a Peachtree dish, they actually fertilize the egg. And then once the egg is fertilized, they insert it back into the female to attach to cause a patient. So they actually put a fertilized egg into the female. So if they're doing that, they also have to do ultrasound monitoring. And usually with IVF, you won't use clomiphene citrate because you're extracting the egg, you're getting the sperm, fertilizing it, and then putting it back in. So you usually won't use clomiphene citrate if you're going to invasive procedures like IVF. Okay, but with IUI, people do clomiphene citrate a lot. So the contraindications are listed here for you if they have liver disease, abnormal bleeding, uncontrolled thyroid disorder, intracranial lesions. They will discourage patients from using it because of one of the contraindications. Counseling points, we usually will tell patients have intercourse every other day, 1 week, starting 4 to 5 days after their last dose. So if they had clomiphene citrate day 5 to day 10, they will start having intercourse 5 days after that. So they'll have intercourse day 14, day 15, around there. The reason we tell them every other day is because if you have intercourse, the first time you have intercourse, let's say I'm gonna have intercourse, a male is gonna release sperm 3 times today, right? The first time the male releases the sperm is gonna be good concentrated sperm, right? The second time they have intercourse, it's not good, the quality of the sperm is not gonna be good, the amount of sperm is not gonna be good. The third time, you're decreasing your chances even more. So what we tell them is instead of having intercourse multiple times every other day, have intercourse every other day to get that quality sperm to fertilize that egg. So the success rate is about 80% for ovulation, and 50% of them conceive within 6 months. And if ovulation dysfunction is the only factor, it usually, you will see 50% of them conceive within 6 months. Maxed for this is 6 cycles. And so what they found was, and all the studies show that it's after 2 years. So if somebody's taking clomiphene citrate for 2 years around the clock, for every cycle, it increases their chances of multiple types of cancers. Okay, and so what most REs are recommending is that you use it less than 6 cycles. Okay, there are some REs that will go up to 12 months of using it, but remember the data really shows you after 2 years. Okay, and if you look at the infertility guidelines that were published by the American Physicians Society, they don't talk about drug therapy at all. So we don't really have guidance to figure out, no one's really evaluated the clinical trials to figure out how much we should be using clomiphene citrate. But a majority of the time in practice, people are using it for 6 cycles, okay? So for the exam, if I tell you that the patient has had 6 cycles for clomiphene citrate, you need to go to a new drug therapy, okay? So max 6 cycles for the exam purposes. In real life, you'll see a small select REs will go to 12 months, but majority of them will go 3 or 6 months, and then they'll move on. Okay, so I skipped over adverse effects, so I am going to cover it because it's important. I want you to know it. So hot flashes, 11% of patients, remember we're messing with their hormonal cycles, right? And so as a result, patients do complain of hot flashes. And some patients complain of visual disturbances. If they see like a ball of light, like a flashing light, we typically will discontinue therapy because clomiphene citrate can affect their long-term vision. And so if they're complaining of that ball of light, you're going to discontinue therapy. And then sometimes people will complain of GI side effects and those things. But it's the only time, if they're complaining of hot flashes, we typically won't discontinue therapy. If they complain of the ball of light, you will discontinue therapy. All right, important to know. All right, so if they go to, let's say, they don't do, clomiphene citrate doesn't work, so they do 6 cycles of it. Then you're gonna go to gonadotropins, okay? Gonadotropins fall into a couple of different ones. So there's a chart that in a couple slides, this chart, these are all the gonadotropins on your left-hand side. So when we talk about HCG, which is on your next slide, right? We talk about HCG, what it does is it induces ovulation. So the only time we're gonna use HCG is when we wanna induce ovulation. If you're not trying to get the patient to ovulate, you're not going to use HCG, okay? So the only thing you need to know about HCG is it induces ovulation, okay? So then the other 3 agents that I have multiple slides about, there's human menopausal gonadotropin, there's urofluorotropin, and then there's your recombinant human follicle stimulating hormones. All 3 of them basically work the same exact way, okay? And in head-to-head trials, they pretty much show similar results. So we don't really care which drug you're gonna use, but you're gonna use one of them, okay? So now I'm going back. So the place of therapy is called, allowing you to do ovarian stimulation for people who failed clomiphene citrate. And so what it does is it allows your follicle to mature and prevents that LH surge from occurring, okay? So you could give any of them, and it's like giving FSH, okay? All 3 of them are like giving FSH. So remember what I told you, day 4, you usually see that decline in FSH. If you give more FSH, you're going to have quality follicles to release quality eggs. Does that make sense? So most of the time, what we'll do with these drug therapies that are listed in the next couple slides is we'll use them to get good eggs so we can extract them for IVF. Okay? And so usually we'll go to these agents only if the patient is doing an IVF. Sometimes with IUIs, if the patient has passed 12 cycles or past 6 cycles of clomiphene citrate, you'll see an RE use one of these drugs. Okay? What do I want you to know about these drugs? Nothing. I don't want you to know anything. Okay? I just want you to know that for these drugs, they're helping with the follicle getting better. Okay, so just know the mechanism of action for it. So that, and like I said, head-to-head trials. So these, and I gave you more details, but it's all FYI information. So like what slide is this? Slide 48. Is this slide 48 for you guys? What slide is it? This one. 49. Okay, so 49, 50, 51, 52 are just FYI slides. Okay? Okay, so then what happens is sometimes you will prematurely release the egg, right? So sometimes you ovulate when the follicle size is 12 millimeters. And so if you know a patient has that issue, then you usually skip the other drugs and you'll go to GnRH agonist or antagonist. So in the picture that you guys see in your GnRH slide, you see that I have the hypothalamus slide for you guys in that picture? Can you see it? Okay. So you see from the hypothalamus, you have release of GnRH. And after GnRH, you have LH and FSH, right? So what happens is there's a feedback loop, right? The way the hypothalamus works, you guys know this? You learned it a few years ago? 2 years ago? 1 year ago? When did you learn it? You keep learning it. Okay, perfect. You learned it last month. So you know there's a feedback loop, right? So if there's too much FSH or too much LH, your body will tell the patient, don't produce any more GnRH, okay? And so what we want to do is we want to make sure that we kind of control that whole algorithm. So we want to make sure that we don't have the LH surge occur prematurely. And so what we try to do is we try to regulate it. And so there's two ways you could do it. You could give an agonist or an antagonist. And I think in your slide set, I talked about antagonist first. So when you are talking about the antagonist, right, what usually happens is it will bind directly to the receptors and inhibit that GnRH activity. So if you're looking at that hypothalamic picture, it will block that GnRH antagonist, so it will prevent that premature LH surge from occurring. Okay? And then when the doctor is ready for that LH surge to occur, and then we do ultrasounds on the patients when they're taking this. So when the patient's follicle size are between 18 and 24, 17 and 24, what they'll do is they'll give a shot of HCG to trigger ovulation to occur. Does that make sense? Yes? Okay. So it will directly block it. We have agonists as well, and agonists, what they do is they block the feedback loop. So they will produce initially more LH and FSH, which will eventually tell the brain, stop making GnRH to produce more LH and FSH. And so as a result, you can use either or. The negative of the agonist is that it causes more side effects associated with it, and so we typically won't use it initially. We'll usually use it after. Okay, so we usually will use antagonists first, and then if the antagonist doesn't work, then we'll use the agonist. Okay, so other drug therapies that we could use. Other drug therapies we could use is aromatase inhibitors. And aromatase inhibitors there's more and more people starting to use them. The big negative is it's pregnancy category X. So you really got to monitor the female to make sure that she's not pregnant before you're going to give this medication. And it works exactly like clomiphene citrate works, where it blocks the estrogen so that FSH can produce and get more follicles. But it is not FDA approved. So they're used primarily for cancer. However, these agents can be used in fertility treatments, and we're seeing more and more REs using them. So and this doesn't have the risk factor of like the multiple. You can use it for 2-3 years. And so if clomiphene citrate you've maxed out on your 6 cycles or 1 year, depending on your doctor, then you could go to one of these agents and it can potentially help. So this is an FYI slide. Progesterone slide, I want you guys to know that. It prepares and maintains your uterus lining, and so it's commonly used in the luteal phase. So once they ovulate, they'll usually start patients on progesterone, and typically they will continue it until the end of the first trimester. And so females, if they do get pregnant during that cycle, they usually will continue it 13 weeks past getting pregnant. Oil suspensions, I wrote ouch because they're really painful, so we typically don't recommend them. And you can't give the natural form because it has hepatic first pass metabolism associated with it. And so we typically will recommend a gel or a suppository, but it's messy. And so it's not ideal. And so suppositories, like if you work in a compounding pharmacy, you'll sometimes compound a lot of progesterone suppositories. That's usually a sign that the patient's doing some kind of infertility treatments. So we do, and the efficacy is pretty much similar. So we usually will stick to vaginal preparations when we're doing that luteal support to maintain the lining. And then I talked a little bit about assisted reproductive technology, about how we have IUI and IVF. And so usually we'll use all of these drugs in combination with either IUIs or IVF. Okay, questions? All right, can we, you guys I have 1 minute. Can I quickly go through the cases with you? Yeah? You have class after this yourself here. So, okay, I'll go through it quick in case you need to get food or a break. Okay, so for this patient, right, LG 28, and if you want to leave because you're like, I'm done, go ahead, please. LG's 28-year-old female who never became pregnant. She's trying to conceive. And so this question is just basically saying that she's 28 years old. She's been trying to conceive for the last 4 months, right? And so we want her to try for how long? 1 year, right? So we're not going to refer her. We're going to, and my exam questions do not look crazy like this. Like my exam questions are like a lot shorter. Like I took all the fluff out of it. I just told you what you need to know for the exams. So second page, so the correct choice is answer choice C. That if they're not successful after 1 year, then they would go to an RA. The second one is a risk factor question, so you can kind of look through the case. I'll just give you the answer for it so you know it, but the right answer is answer choice C. But basically you have to go through, and this is typical of something that I would put on my exam, where I want you to count up the number of risk factors they have and what you're going to counsel them on. On my exam question, I just asked you for a number, so you do need to know your risk factors. The drugs associated, like the 2 drug slides that I gave you with medications, you need to know those medications. Number 3, the answer is clomiphene citrate. So basically she has PCOS, first line treatment for that when you have infertility is clomiphene citrate. Number 4, which of the following most likely to cause? The answer choice is D, it's all of the above, right? Because the patient's over 35, that's a risk factor. They had gonorrhea, which is a risk factor. Cigarette smoker, they're a risk factor. Okay. The number 5 is ovulation home predictor test. I wouldn't give you a question like this that covers, like it wouldn't, an answer choice wouldn't be saliva electrolyte monitor because I didn't ask you on that. But there is a couple of questions related to the basal body temperatures and basal body temperature and the urine tests. So you do need to know those two for the exam. Number 6, the answer choice is choice D. So this patient had tried for 4 months on a 50 milligram daily dosage, and they got follicles that are greater than 18. So that shows that it is working for them. And they have no other issues, so what would you do? And so you wouldn't move to the gonadotropins yet because you would want to do 2 more cycles of clomiphene citrate before you go to them. Okay? I'll stick around for a little bit. Good luck with your exams. You'll see me because I'll probably be at one of your finals. But good luck with everything for the rest of the semester and on rotations.